My name is Jiang. I come from Guizhou Provincial People's Hospital, and I searched the Congress program this morning. There are at least 4 presentations focused on the fourth tendon and the ventricular arrhythmia and the left ventricular tachycardia. So I hope we will enjoy my version. Yeah, the fourth tendon are string-like structures that connects the ALV septum, free walls, and or the pulp muscles. And the fourth tendons do not connect to the mitral valve apparatus as the force it was in use. And this review literature has summarized all the fourth tendon studies. And the fourth tendon was prevalent in 34 to 68% in human autopsy studies, but the presence in echocardiography studies was varied from 0.5% to 78%. The Framingham study has summarized the odds ratio of identifying the FTs by transthoracic echocardiographies. As we can see from the table, the LV hypertrophy and the reduced ejection fraction was associated with higher incidence of the fourth tendon on the echocardiography. However, the fourth tendon was not associated with the total mortality in the population. And one possible explanation from the authors was that the ventricular hypertrophy and the reduced ejection fraction may create some condition for the technicians to better identify the fourth tendons. And it is now believed that the fourth tendon are a frequent finding in the general population. The Locus group in 2007 has classified the fourth tendon according to their connections into 5 subtypes, and following histological studies identified the myocardial cells in type 1, type 3, and type 5 fourth tendon. The Phillips conducted a study using the congenital heart disease specimens. The histological studies has classified the fourth tendon into 3 types according to their contents and the diameter. The first is a fibrosis type, occupies nearly half of the fourth tendons, has a diameter less than 1.4 millimeter. This type has no myocardium within it. And the second is the fibromuscular type, over half, with a diameter more than 1.5 to 2.4 millimeter. And the last one is the muscular type. It contains two types of conductive tissue, the Purkinje cells and the myocardial cells. This type, the diameter was the longest, with over 2.5 millimeter. And in the patient who had ischemic VFib, the heart sample showed there were three fourth tendon connected the left posterior septum to the posterior pulp muscle. The histological findings, there were abundant Purkinje cells inside the fourth tendon. And the fourth tendon, as we can see in these 2 pictures, the fourth tendon is loose in the systole and is taut in the diastole. And the abrupt stretch in the end diastole may produce delayed after depolarization, accelerated repolarization, and shortened action potential period. This phenomenon was demonstrating enormous animal and human studies. It's abnormal mechanical electric feedback. And as the tensions, as the stretch may be chronic over cardiac cycles, like the athlete's heart, the myocardium attachment, which suffers the great stress of the stretch, will produce myocardial scars. And in this study, the Dr. Borg has provided the late enhancement imaging of the cardiac MR. And in these 3 patients, the false tendon itself and the septal attachment myocardium show delayed gadolinium enhancement, indicating scar formation in the attachment there. We conclude false tendon significance in ventricular arrhythmia into following 4 points. First, the false tendon has 2 conduction pathways, including the myocardium and the Purkinje fiber. And second, the false tendon has increased triggered activity or automaticity due to abnormal mechano-electric feedback. And the myocardial scars residing in the attachment and the false tendon itself will form a slow zone for maintaining the reentrant tachycardia. And the fourth is the overbridge anatomy of the false tendon. It forms an anatomical obstacle in the middle of the myocardium. Fascicular VT is first described in 1970s by Cohen and Zippis. The fascicular VT is characterized by a narrow coax duration, superior axis, and right bundle branch block, sensitive to verapamil, and the absence of the structural heart disease. The origin was first thought to be micro-reentry or a focal source within the left posterior fascicular. The first association between false tendon and the fascicular VT was made in 1989. A young patient without any heart disease had recurrent ventricular tachycardia, and the electrocardiography identified a false tendon arose from the septum to the apical, and the surgical removal of the false tendon completely eliminated the ventricular tachycardia. And the histology of the removed false tendon showed abundance of the Purkinje fiber within the false tendon. Another evidence was made by Tucker in 1996. They found the false tendons were present in all the patients who had fascicular ventricular tachycardia, but the presence was only 5% in control patients. And if we want to state clearly the relationship between false tendon and the fascicular VT, we should go over the milestone evidences that had illustrated the mechanism of the fascicular ventricular tachycardia. In 2000, Dr. Nogami mapped 2 distinct potential in the left middle septum by using a multipolar linear catheter. Yeah, this one. The first potential was the P2. It was a high frequency, short duration potential, which conducts from proximal to distal in the sinus rhythm. And during the tachycardia onset, the P2 conducts from distal to proximal. And the second is the P1 potential. It was usually buried in the V wave during sinus rhythm, but it preceded during ventricular tachycardia, and it conducts from the proximal to the distal. And in some level of the multipolar catheter, the P1 will fuse with the P2. And in some other literature, like the Malaruma published in 2001, the P1 was also seen during sinus rhythm. It conducts from distal to proximal at the end of the V waves. Dr. Nogami has demonstrated the P1 was the critical part of the circuit. It's an anticoagulant. He used the progressive fusion by overdriving pacing the left mid-septum ventricle to demonstrate the P1 is the critical part. In this figure, P1 was captured by overdrive pacing, and the overdrive pacing entrained the tachycardia and reset the tachycardia cycle length. The P1 was captured, since the P1 was captured in the entrainment, so P1 was identified as a critical part. And then as the pacing cycle length shortened, SP interval increased 45 milliseconds, and the slow conduction was identified in this figure. This fast pacing also entrained the tachycardia and reset the cycle length. And he also gave a picture of a spontaneous sinus rhythm which captured the P2 during the tachycardia. The P2 was preceded 55 milliseconds and reset the tachycardia cycle length. So P2 he presumed to be the retrograde link in the tachycardia. He has hypothesized the circuit schema in 2000. The circuit is composed of the P1 and P2. P1 serves as antegrade conduction and slow zone, and P2 is a retrograde link. However, the P2's role in the retrograde conduction in the circuit is being doubted. In 2012, and this group, Malishima group, published this paper. There's also a spontaneous sinus rhythm captured the proximal P2 on the multipolar caster. The distal P2 signal was not captured. The P1-P2 signal, the P1-P2 interval, the cycle length was not reset by the proximal capture of the P2. So they postulate the proximal left posterior fascicle was not the retrograde link. It's not relevant. And later, Mieda group report this case. The ablation catheter was placed. The tip of the ablation catheter was placed at where the P1 P2 signal fused together, and we can see that during the ventricular tachycardia onset, P1 conducts from proximal to distal, and P2 conducts from distal to proximal. After the ablation initiated, as soon as the ablation initiated, the P1 P2 separated, and the P2 sequence changed from proximal to distal, and the ventricular morphology changed from a more distal exit to a basal exit. And in this change of the with this P1 P2 interval change and P2 sequence change, the cycle length of the tachycardia did not change. That means that cycle length could be intact while the P2 did not participate in. To 2016, Dr. Liu Chang's group has published the famous paper that the left septal myocardium is part of the circuit. They deliver an extra ventricular stimuli from the right mid-septum, and the extra stimuli captured the proximal left septum ventricle here, and then the cycle length was reset The distal P1 P2 signal and V signal was not captured by this extra stimuli. This figure identified the left septal myocardium is the part of the circuit. And in 2016, they refined the circuit schema like the following. The P1 serves as the antegrade link, and it has one side or multi-side fused with the left posterior fascicular. And the myocardium serves as a retrograde limb, and a slow zone connects with the myocardium and the proximal P1. In some of the fascicular cases, the P1 fused with the left posterior fascicular together. P1 fused with P2 together, and the distal P2 forms the antegrade part of the antegrade limb. And in most of the cases, there's only connection between P1 and P2. The P2 is just a bystander in the circuit. Until recently this year, the false tendon is identified to be culprit in majority of the fascicular VT. Liu Chang's group found the false tendon was present in all the patients who had catheter ablation for false fascicular ventricular tachycardia, and over 96 of the patients had inculpate false tendon, in which the P1 could be recorded, or the earliest P2 could be recorded in the false tendon region. Only one patient had earliest P2 recorded on the pap muscle. No P1 was recorded. The most prevalent false tendon was this type 2, arose from the left septum to the distal of the apex. Then they refined the circuit schema this year. A false tendon was included in the schema. The P1 and the P2 fiber travels parallelly in the false tendon, and the P1 still the antegrade limb in the circuit. In some level of this P1 P2 false tendon, the potential could the insulation could be broke. The activation could be conduct between this P1 and the P2, and then the ventricular the myocardium serves as the retrograde limb, and they're still the slow conduction zone and the proximal attachment at the proximal attachment of the false tendon. And the slow conduction, the location of the slow conduction they hypothesized is coincide with the previous CMR results that the scar formation was located in this region. And as the FT contains myocardium and Purkinje fibers, there's no surprising they can produce PVCs, premature ventricular complexes. In 2021, Dr. Jiang Lin published a heart rhythm paper. There were 10 patients who had ablation for false tendon related PVCs. All the targets were located on the septal attachment or the distal attachment of the false tendon. And in one patient who had a false tendon arose from the left septum to the tip of the pap muscle, the initial ablation ablated the pap muscle type ventricular tachycardia, and then the premature ventricular contract, and then the morphology suddenly changed to a second one with the exit more basal, and the PVC was limited in the target 2. And it's no doubting the fascicular, the false tendon is important in the ventricular fibrillation. It acts as a trigger, and most cases are published in single case articles. And to our experience, we have over 80 cases on the left fascicular ventricular tachycardia. We do not even see the P1 signal clearly because the 3.5 millimeter 8 French ablation catheter cannot clearly record the P1 potential. In a summary, false tendon is prevalent in majority of human hearts. False tendon is potentially arrhythmogenic because it contains two conductive pathways. increased triggered activity caused by the abnormal mechanical electric feedback. It has slow zone in its two attachments, and its over-bridge anatomy form an obstacle above the endocardium. The fourth tendon should be suspecting endocavitary ventricular arrhythmias, and eyes and closely spaced mapping casting are recommended. And that's all my presentation. Thank you.